Hello again, MBA students. This is Antioch 5420. My name is Dr. Ron Kapp, and we are on week 5. Hard to believe, but we've made it this far, and let's keep going. This week, I'm going to talk about insurance. Can't live with it, can't live without it. I put insurance saving all of us. In fact, as you'll hear today, insurance is critical to the functioning of our healthcare system. Without insurance, you're basically one step away from financial disaster. Unfortunately, insurance is very contentious, debatable, and it's a topic that is in the news quite often, and everyone has their varying opinions about what should or should not be done in the insurance market. What I'd like to try and do this week is unravel some of these different conundrums, some of the beliefs and some of the history that has led to our current crisis in the insurance industry, so that you have a better understanding when you go out into the workforce. We all remember Dallas. Teachers Union, 1903, buy your insurance for $6 per year. Well, a little over 100 years later, President Obama was able to pass the Affordable Care Act. It was in March 2010. We call it Obamacare. Most people call it the ACA. The ACA is an attempt to do what they did in 1903, 100 years later. And I think anyone who has read the newspaper within the last few years realizes how contentious the ACA has become. It was politicized between the different political parties. For 2022, the IRS has announced the limits for the health savings accounts, HSAs, and these what are called high deductible insurance plans. So for 2022, the out-of-pocket limits for an individual person, $8,700. For a family, it's $17,400. In other words, that's how much you will pay if your medical bills exceed that. Then they put out-of-pocket limits for the HSA qualified HDHPs, a little more complicated. The self was $7,050, family $14,100. A little bit higher than 2021, accounting for inflation. When you realize how much healthcare costs, and I think we all know that now, I had one surgery in my life, and the bill after 2 days in the hospital amounted to $189,000. We need insurance. So this is just sort of a quick brief of 1903 to 2010. Now, the business of illness, as you have heard over the last many weeks, encompasses many different facets. It is a revenue generator for many, many people. There is a way that we can, of course, make more money by manipulating the system. The business of illness and the business of medicine is quite large. There are supply chain optimization programs. There's a minimization of corporate tax liabilities that brings the accountants on board. Many MBAs get involved with innovative business modelings. Basically, we're selling products, the medicines, the devices, the surgeries. We're selling professional services by the physician, the MD or the DO, the registered nurse, the physical therapy, the occupational therapist, the whoever therapist. Bills to be paid, and the different diverse insurance products are there to go all the way back and pay all those bills. So right there, this slide, you can see how complicated and complex the business of medicine is when you have all these different entities that need to be involved and paid. I like this quote. It is a true reflection of America's problem, and I've heard it in many different forms. I'm sorry, we can't do the surgery for what your insurer's willing to pay. Or, I'm sorry, your insurance doesn't cover that medication. Or, I'm sorry, your insurance doesn't cover physical therapy. Or, I'm sorry, you get the point, your insurance doesn't cover home care, nursing home care, long-term care, on and on. This is a very common quote. Having been in the medical business for more than 30 years, I have heard this quite often, and I think it's becoming more and more common as we move forward. I don't like hearing this, but that's reality. Slide. These rich versus poor, the six down there. And then he has to cave on anything that would directly limit the industry's ability. To cave on anything that would directly, Nobody wanted to give up a piece of the pie. They wanted to keep their money. So it got very complicated. It was a real a true business negotiation that he was trying to pull off in the Congress. That was in 2010. It passed, March 2010, but it was undermined as it went forward. It was undermined by three groups: the politicians in Congress, by the insurance companies themselves, and most critically by the hospitals and doctors involved in the system. So let's talk about these three: the politicians, the insurance companies, and then the hospitals and doctors. The politicians. There was a entity called the Health Insurance Cooperatives that were developed. These were not-for-profit insurance plans that were member-owned and directed, where they used the premiums for high-quality medical care. Gee, that sounds familiar, doesn't it? Baylor Bear from 1903. Not-for-profit insurance plans. These were independent. These were brand new, called Health Insurance Cooperatives. Now, very few people heard about these. There was no publicity. But more importantly, these plans competed with President Obama's promise of a national health insurance for everyone. Obama said many times, we are going to have a national health insurance. We're going to allow everyone to join Medicare. As you recall, Medicare, the plan, federal, people over age 65, automatic. But what if we let younger people join? What if we let other people join the Medicaid program? So that competed with the hospital insurance cooperatives, for those who even knew about the health insurance cooperatives. And then the final nail in the coffin was, of course, Congress, who in 2015 only offered 12.5% of the needed money to get these health insurance cooperatives up and running. So virtually all closed. I think only one remained, that was in Maine, that had a minimal profit, but all the other ones closed. They said, we can't do this. We weren't funded. We're getting no publicity. We can't compete with the national health insurance. So in effect, the politicians killed this portion of the ACA. Don't worry, there's more. Yes, the more is the insurance companies. The insurance company said, sure, we'll join on. We will offer high deductible plans. Great. A $5,000 deductible is not going to do much for many people when they only have $1,000 in the bank, $10,000 plans, whatever. But high deductible plans are great in theory, do not work that well in reality. Then the insurance company increased the patient copay amounts. In other words, you have to pay a certain amount of money before your insurance kicks in. Well, again, if you don't have much money in the bank and you have to pay a copay, that's sort of a conundrum. Then the insurance companies developed narrow and limited networks of coverage. They said, for example, we will cover your children until age 26. Great. But only if you're in state. If the children move out of state, we don't cover them. Well, guess what? It turns out that many children in America do move out of state. They move to have families. They get jobs. Many of them go to college in other states. So if your parents live in California, your child goes to college in, for example, Texas, there's no coverage. You have to fly back to California. It was just very logical on the insurance company's point of view, but illogical from the point of view of providing for patients. And then the insurance company offered limited local coverage in many areas. They limited the specialists. Most specialists like to go to big cities. It's where the patients' clients are. That's where the money is. That's where they can do lots of procedures and capture their patient base. You're in a rural area. You're out in the middle of West Texas or somewhere in the mountains of California or Wyoming or Colorado. There's no specialists. You have to travel a long way. And then the final, again, nail again. They offered tiered coverage, the platinum, gold, the silver, the bronze. And I put question marks there because no one, absolutely no one understands what this means. You can talk to insurance agents. They don't even know. I've tried, believe me. So the insurance companies were complicit in this ACA demise of not really pushing it forward as much as they could have. There's more. Yes, hospitals and doctors were also involved. And the main thing that I'll say we, because I am working in a hospital, we use creative and aggressive billing concepts. For example, the ACA says a physician must do a free physical exam, but not the blood testing. Well, in today's high-tech world, while a physical exam is fantastic, you need blood testing, you need radiology, you need other services, and those cost money. So they weren't free. So the physical exam was free, but the ancillary services cost money. The ACA mandated that we had to do preventive screening. But then if something is detected, it's no longer prevention, it's treatment. For example, take a mammogram. Ooh, found a spot. We have to do a biopsy. Simple in and out with a needle, get a tissue sample. That's going to cost money. Same thing with the prostate exam. Well, we'll check your prostate. Oh, it looks large. I think you have we better get a PSA. Oh, you got to pay for the PSA. Oh, you got to pay for the biopsy. Everything then was added on. And then the final nail, the doctor fee was covered. Yeah, it's free. Sure, you're seeing me free. But you know what? We have to charge you for a room rental fee. And we've talked about this before, room rental fees. Medicine, really, other than a hotel maybe, is the only place where you have room rental fees. And if you go into an operating room, there's a fee. Go into a little clinic room, it's a fee. So that really was a sort of an add-on. Result of those aggressive and billing concept was that patients avoided medical care for fear of hidden costs. They said, well, I can't go to that doctor. He's going to charge me if he finds something. And then by 2016, many of the large insurers dropped all the ACA plans. They said, we just can't do that. We're losing money. We can't do it. We don't want it. We can drop it. Those that did survive, that stayed with the ACA, and there are a few, they just raised their premiums 40 to 60%, obviating what we were trying to do, which was to save money all along. So the hospitals and doctors also were also very complicit in not really supporting the ACA as much as it should have been supported. Now, don't get me wrong. I'm not saying the ACA was bad. I think it was a great idea. I think it's working. It's just hasn't been refined enough, and now it has become very politicized based on your beliefs, Republican, Democrat, Independent, Socialist, whatever. So it makes it a very difficult insurance product to not just understand, but to continue to improve. So what were the MBA business lessons from the ACA? Don't you love these acronyms, MBA, ACA? Elizabeth Rosenthal wrote this book, An American Sickness. It's in your syllabus. I've referred to it many times. She said, quote, many skillfully danced around the Affordable Care Act's goals to minimize the financial impact on their business. In other words, I'm keeping my money. Second lesson for the MBA, in healthcare, entrepreneurship outsmarts regulation every time. Rather interesting lessons for an MBA to learn, but again, you have to realize people do not want to give up their money. They want to keep doing what they're doing the way they're doing it. You may like that book. What has developed in the insurance industry, the concept of medical coding. It makes everything work. And coding is a fantastic idea. But as we do it in the United States, That format does not exist in any other healthcare system in the world. Now, coding is old. It started back in the 1890s, more than 130 years ago. During the bubonic plague, the French physician Bertillon had his classification of the causes of death. And that was an official global effort to see how many people in the 1890s were dying from the plague. It was a lot, but they wanted to track it. Admirable. In 1948, the World Health Organization, WHO, renamed that classification the International Statistical Classification of Diseases, Injuries, and Causes of Death. ICD, in other words. ICD is something you have to know. International Classification of Diseases. That was in 1948. And then in 1979, the U.S. government decided to use the ICD codes for billing of Medicare and Medicaid plans and claims. And as you already know, once Medicare does something, most other insurers follow the Medicare lead because so many people are on Medicare. It's the federal government. It's a nice, easy transition. So the ICD codes are what we use now to do our billing. When you hear this term ICD, you'll know what they're talking about. You'll say, oh, that was in the 1890s when they had the bubonic plague, and people will look at you like you're some kind of nerd. But now the race was on. I was there. Coding became big money. What developed in the United States was 3 different alphanumeric coding languages. The CPT, for Common Procedural Terminology, you'll hear this all the time. What's a CPT code? The ICD, we just did that one, the International Classification of Disease, and the HCPCS, which I never hear of, Healthcare Common Procedural Coding System. These are independent languages. They're as independent as Spanish is from French, is from Hungarian. You know what I mean. You understand. In 1996, the Medicare held an initiative. It's called Medicare's National Correct Coding Initiative. It was an attempt to fix all those CPT, ICD, HCPCS codes. And they said, look, you cannot combine an ICD code, International Classification of Disease, that's for a diagnosis, with a CPT, which is a Common Procedural Terminology code, is double billing, is double dipping. You can't do double dipping in that. However, the government, in its infinite wisdom, also created at the same time modifier 59 codes to allow exceptions. The exceptions were many and rampant. Abuse was everywhere. So just add a modifier 59 and you're off to the races. We're now currently in the ICD-10. I think it may be even an ICD-11 coming down. But ICD-10, the global coding, was completed in 1992 for the entire world, implemented in the U.S. in 2015. Looks like 23 years later to me. I think that says it all, doesn't it? The race was on. We were dragging our feet for a variety of reasons, but we did join the race. And now, when you are a coder, you are a very valuable person because you understand all these different alphanumeric coding languages, and everyone in the industry looks to you for how does this get coded? We can't even order tests, in fact, when you go to LabCorp or Quest or radiology exam until the ICD and CPT codes are put on that order sheet. These are long, complicated codes. We have big books for this, and we go to our coders and ask them, what's the code so I can order this blood test? I want to get a blood count on this patient and see if he's anemic. Well, doctor, you can't do that until you know what the CPT ICD code is. It's a little bit frustrating, yes, but it's also a regulation. Don't get me wrong. I believe in coding because we needed some way to control this massive system known as the healthcare world in which we live. But who controls and directs the coding billing race? Now that is a good question. Well, guess what? Yeah, you know, it's the AMA, the American Medical Association. As we talked a few weeks back. The AMA was founded in 1847 by 250 different doctors. They had 4 stated goals at that time. Their goals were scientific advancement. 2 was standards for medical education. You remember the Flexner report later. Medical ethics program and public health improvement. That was the original goal for the American Medical Association. By 1962, Milton Friedman, University of Chicago, great economist, I think we all know him. As you're an MBA, you better. He called the AMA, quote, the strongest trade union in the USA. Rather interesting quote for the early 1960s. Yeah. Now, the AMA. Nearly all doctors joined. That is until the late 1990s. Now it's about 25% of physicians who join the AMA. FYI, I happen to be a member of the AMA. I believe that I want to support them, and they also have a lot of products that I can personally use, such as my own personal insurance program. I get their journal JAMA, I read that. In fact, they publish this JAMA. It is the most widely circulated weekly medical journal in the world. JAMA, J-A-M-A. We call it JAMA. But the AMA also owns the copyright for the CPT codes. They have a 17-member CPT editorial panel that looks at these codes and decides which diseases should be coded for this and what procedures should be coded for this and how it should work. The AMA spends about $20 million annually lobbying Congress, but it's the political action committees that really contribute millions to political campaigns, many more than 20 million. The AMPAC, they call it. And the primary focus of the AMA for the past 15 years, although they do many things, as we've already elucidated, but basically they're filing lawsuits against insurers over how to calculate, quote, usual, customary, and reasonable fees, and also opposing Medicare's public release of payments to physicians. Now, like I said, this is going to be more of a debatable, contentious lecture. I personally believe we should release the public data of how much physicians are making, but that's my own personal belief. Others say, no, I don't want to have people know that I'm making $850,000 a year or something crazy like that or more. That's nuts. So the AMA is there as a lobbying group to go to Congress, one of the biggest lobbying groups in Congress. And you can debate the pros and cons either way, and we can do that in a discussion if you want, but that's something for you to think about on which side of the fence you would like to be on. More importantly than the AMA, far more important than the AMA, are the medical specialty societies. Now, these are the true lobbying interests. They spend more than $500 million annually lobbying Congress, the Senate in Washington. The different political action committees, every group has them, from radiology to neurology to cardiology, American College of Cardiology, PSC, orthopedic, skin for derm, family practice, NEM, National Emergency Medicine. All these different political action committees, they're nonprofit charities that then lobby Congress. In addition to those, you have the American colleges. We talked about the different specialty boards. Remember the American Specialty Board, the American College of Emergency Medicine, American College of Cardiology, American College of Neurology, 24 of those. They also lobby Congress. So we have all different amounts of money, of course. So all the different lobbyists that are pushing the agendas to protect the pieces of the pie. Something to think about here. We say, wow, these are good. There are good benefits to these. I'm going to talk about that right now. You've heard of this. You've heard of the standard of care. This is what insurance companies follow. What is the standard of care, doctor? This is what doctors practice. We practice standard of care. This is what patients want. Doctor, you're practicing this. Yes, this is what we do. And the standard of care drives the medical malpractice field for all attorneys. I put the 4 elements of a medical malpractice suit there because I think you need to know about this. Number 1, you have to have a duty of care to that specific patient. Number 2, you have to breach the duty. The doctor has to violate the standard of care. Number 3, there has to be proximate cause. In other words, what I did as a doctor has to have caused whatever the patient complaint now is. Proximate cause. They have to be cause and effect. There's a chronological relationship. I can't do something today and then the patient comes back 3 or 4 years later and said, that pill you gave me 4 years ago caused this rash. There's no proximate cause there. And the 4th element of a malpractice case has to be patient damages. There has to be some harm to the patient. I can screw up on the first 3, but if there are no damages, there's no suit. But the standard of care drives this medical malpractice field. Now, do I worry about this? Oh, absolutely. But do I stay up at night? No, because I have malpractice insurance. And it's a large amount of money. I practice emergency medicine. It's a significant portion of the payment that I receive goes to the malpractice companies, insurance companies, to have this insurance. For other specialties like OB-GYN, neurology, it's far higher. All the surgical specialties are higher than emergency medicine. But again, when you think about who's paying the final bill, it's always the patient. Always goes back to you, me, the patient. So I want you to know a little bit about the standard of care and why it is so critical to what we're doing in our medical world. But who defines the standard of care? Well, it's defined by science. We do research, defined by the lawyers, of course, the mid-mal arena, and by the insurance company. But mostly the standard of care is defined by those specialists who perform the procedure. They're defining the standard of care and they're making money. They write the guidelines on how and when things should be done. For example, PSA for prostate-specific antigens, which we don't do as much anymore, by the way, all defined by urologists. Mammograms, all defined by radiology. Arthroscopy for your knee or shoulder or whatever joint, defined by the orthopedists. Bypass surgery by the cardiologist. Cholesterol statins, defined by the family practice guys and maybe some cardiologists. This is the way it should be because they are the ones practicing in that area. Therefore, they know the best medicine. They know the best science. They keep up with the research. But there's also some bias because they are defining the standard of care, which then generates their income at the same time. Again, 2 sides of the coin, debatable depending on which way you want to look at the data. So, what is the MBA take-home lesson? Well, everyone wants the standard of care. Who doesn't? I want the standard of care. I want the best. I want what science says I should have. The question is, how do we deliver that? Who is going to pay? And how are we going to pay? As I said earlier, most people are one unlucky step away from financial disaster. Therefore, the ACA or some type of insurance product to prevent that financial disaster. And the second thing that has happened, and we're going to talk about this more in the weeks to come, we are numb to statistics, especially statistics about medical debt. Oh yeah, medical debt, so what? It's like student debt in college, graduate school. We become numb to the numbers. And the real take-home lesson is we love our doctors, but we hate the system. That's the true take-home lesson. You love me, but you hate what you're hearing here in this lecture. Because that's the complexity of our system. And then we look to you, the MBA, as we've talked many times, for solutions. Yes, solutions. You're not going to get those here in week 5, but there will be some solutions in week 7, so stay tuned. And that is the end of week 5. Thank you for listening. My name is Ron Kapp at Antioch 5420, and let's move on with the rest of the work for this week. Thank you for listening.